It now gives me great pleasure to introduce our first speaker, Dr Helen Bevan. Dr Bevan is Chief of Service Transformation, the National Health Service Institute for Innovation and Improvement, the UK. This is an organisation that supports 1.3 million staff of the English NHS to accelerate the delivery of world-class health and healthcare by encouraging innovation and developing the capabilities of the frontline workforce in delivering patient care. In the past 15 years, Helen has led change initiatives at a local and national level which have created improvements for millions of patients across the NHS. Her current role is to keep NHS improvement and knowledge fresh, relevant and at the leading edge. And in 2008, the 60th anniversary of the NHS, Dr Bevan was named as one of the 60 most influential people in the history of the NHS. Would you please welcome Dr Helen Bevan.
Thank you, Mark, and good evening. I bring greetings from the English National Health Service. And what I'd like to talk about this evening is a topic that I think is relevant to all of us who are thinking about health systems in the future and how we create viable and accessible healthcare at large-scale change. And what I want to talk about is the role that leaders need to play in terms of large-scale change. So the context for my presentation this evening is what is happening in the National Health Service in England and some of the challenges that we face. So, few headlines. The reform process that is happening in the NHS at the moment is very significant. In fact, the changes that we're going through now are the biggest since the English NHS was founded in 1948. We have a seismic change that is happening as resources and focus is moving away from large acute hospitals into primary and community care. Because most of the people who use our NHS services are people with chronic conditions, frail older people increasingly, who we want to look after in the community and require less people to go to hospital. Underpinning this is a particular change, which is that 80% of the expenditure of the NHS is going to be allocated via clinical commissioning groups, general practitioners, family doctors, and they're going to be making the decisions from 2013 onwards at a local level. And in a sense, they'll decide whether we invest, say, in intensive care beds in hospitals, or whether we provide instead services to keep frail older people out of hospital. So, if we just had the reform process going on, I think it would be challenging enough for our leaders. But the fact is that Britain was impacted by the economic downturn much more significantly than Australia was. And we have a financial gap of about £20 billion, which is 30 billion Australian dollars, that has to be realised by 2014. And what this means for our system is for 4 years running, our finances are reduced by 4%. And if you look at healthcare systems across the world, it's absolutely unprecedented to see that level of reduction year on year. So as a leadership community, we face some very big challenges, and an understanding that many of the approaches and methods of change that we've used as leaders in the past probably aren't going to be enough. So over the last couple of years, I've been working with 80 of the most senior clinical and managerial leaders in the National Health Service in England to think about and to test methods of large-scale change. And what I want to share with you this evening is 5 of the key messages that has come from the work that those leaders are doing. But first, a very big message. Every revolution begins with a transformation of consciousness. And what we mean by that is if we look at history, if we look across the world, what we can see is that whenever large-scale change happens, whether it's an industrial revolution or large-scale change in a healthcare system, the first thing that has to happen is that leaders have to think differently. You know, we will not be able to achieve the reforms, the improvements that we need to make around productivity and in quality improvement if we keep the same thinking. So that brings us to message number 1. We have to match the way that we think about change and how to go about change with our ambition. So I'd like to show you a little bit of data. This comes from McKinsey Management Consultants, so it has to be correct. When we look across the world at efforts at large-scale change, at transformation, what we see is that only about 1 in 3 of those transformation efforts gets anywhere near achieving its objectives. And only about 1 in 20 actually exceeds expectations. So what we need to think about as healthcare leaders is what are the actions that we can take so that we're at least part of the 30%. And, you know, one of the things I'd say is that certainly when I look across our system in England, I think much of the thinking is what I'd call first-order change. And what we mean by that is that when we think about how we need to change the healthcare system, we can only see it as more of or less of what we know already. So when I think about that in terms of the cost and quality challenge that we have in England, what we talk about is, you know, we've got to have very clear goals for improving costs. We've got to reduce our budgets across the board, reduce waste in the system. We need to think about how we can work harder and make better use of measurement. So I would describe that as tighter control and scrutiny and how to improve our management grip. And of course, you know, we need to do this, but it won't deliver $30 billion by 2014. It just isn't enough. So we need more what I'd call second-order change. And this is the kind of change where as leaders, we stand back, we say, can we see things differently? What's the big picture here? And those leaders in our system that I see who are thinking in second-order ways are saying, let's understand what the variation is in the system. You know, why is it that in one part of the country, you're 5 times more likely to get a tonsillectomy than another part of the country when there's no apparent clinical reason for it? Let's talk about our cost improvement goals. Of course we need to reduce costs, but let's reduce costs by improving quality and safety. Let's make a compelling case for change and get lots of people involved. Let's create the capacity and capability for change. And those leaders in our system that are thinking in second-order ways, what they're doing is creating a call to action to the whole workforce, to the whole community around radical system redesign. So of course we need first order change, but I reckon at the moment it's probably about 80% first order and 20% second order. And where we need to get to is much nearer 50-50. So let's hurtle on to message number 2. And that we need to focus on energy. You know, how do we manage our own energy as leaders and the energy of the people around us? Because certainly in England, you know, when we look forward at financial projections, it isn't the case that we're going to have 4 or 5 lean years and then the system will go back to normal. You know, things are never going to be the same again. And I think our financial challenges will go on for a long time. And I also think we'll see that in healthcare systems across the world. And when we think about energy in organisations, there's 4 types of energy that I see. And the first one is intellectual energy. And this is the kind of energy that's about analysing, about logic, planning. The second energy is emotional energy. This is the kind of energy that's about how we connect, the relationships that we build, partnerships and collaboration. The third kind of energy is called spiritual energy. And this is the kind of energy that is about how we create hope for a positive future. It's the kind of energy that makes people sign up for change and feel more positive and confident about the future. And the last kind of energy is physical energy. Again, very important. It's the energy of action, implementation, getting things done. Now, when I look across healthcare systems generally, what I'd say is there's one of those energies which is more prevalent than all the others. Does anybody want to shout out what they think it is? Yeah, it's physical's, I would put physical number 2. I'd say it's intellectual. You know, when we think about our cost and quality plans in the NHS, it's let's plan for change. And then what we do is we combine that with the physical energy. So it's here's the plan, let's get on and do it. And you know, when we think about transformation and leaders and systems that have created large-scale change, what they're focusing on is linking that physical energy with emotional energy, which is the energy of partnerships and relationships. But what's really important for transformational change is spiritual energy. And I think that we've got a really big responsibility as leaders to create that sense of a hopeful future where we can take people with us. And certainly I have a strong sense in the National Health Service in England that a lot of radical changes are required. But in terms of securing the future of our system and having a public health system that is comprehensive and available to everybody, regardless of ability to pay, is definitely our future. Okay, number 3. Build leadership systems that are managerially loose but culturally tight. And I think that, certainly in our system over the past period, we've had far too much managerialism, micromanagement. And maybe a way to think about this is that we've been very, very focused on compliance, okay? If we look at the first column there, this is the minimum performance standard that everybody must achieve. This is the 4-hour wait emergency room target. If we don't achieve this, we're in trouble. We use hierarchy, we use performance management systems and standardization to coordinate and control. And if we fail to achieve our compliance goals, there are serious consequences, penalties, sanctions, shame, okay? Of course we need to have compliance in healthcare systems, but if we look across the world at experience of transformational change, no system has ever been transformed through compliance. We need to think about commitment. And when we talk about commitment, we say this is a shared goal that what we want for the future, that everyone can aspire to. It's based on having goals and values and a sense of purpose that we all share, all moving forward in the same direction. And how we create energy for delivery is by commitment to a common purpose. Again, when we look at the history and experience around radical transformational change, it's nearly always built on a platform of commitment. So when we think about our role as healthcare leaders into the future, it's about building commitment on a massive scale. Number 4. Oh, I forgot that one. This is so true. This comes from Edgar Schein, who is a leader of a guru on organisational development. You can't impose anything on anyone and expect them to be committed to it. And yet when you think often with our clinical workforce, the way in which we force our colleagues to comply with performance goals, the reality is it doesn't work. And this is a great slide. This comes from Benjamin Zander, who is the conductor of the Boston Philharmonic Orchestra. And he says, a cynic, after all, is a passionate person who does not want to be disappointed again. And it seems to me that healthcare is full of passionate people, okay, who came into the health system to be a clinician because they wanted to make a difference, they wanted to serve, and yet the system has turned them into cynics. So, we really need to think about how we connect with and unite that passion. Number 4, thinking about, who the leaders are and what are leadership boundaries within a healthcare system. And I just wanted to tell you about one of the schemes that I'm involved in that I'm really proud to be part of. This is an initiative across Britain, and it's called The Right Prescription, and it's a call to action on a situation which is a national scandal. And it's the situation of people with dementia who are inappropriately given antipsychotic drugs that act like a chemical kosh. Turn people who have got a right to life into an effective life into zombies. And we have a goal that by the 31st of March next year, all 180,000 people with dementia in England who are being given antipsychotic drugs will have had their situation reviewed and only be being given medication if it's antipsychotic medication if it's called on. And you know, I work in a lot of improvement projects in the National Health Service in England, and normally I'd work with doctors and nurses and managers. But through this work, we've completely rethought who leaders are. So we're working with leaders of care homes. We're working with leaders of the major pharmacy chains. We're working with a whole series of voluntary sector leaders. And, you know, it's really making us rethink who are the leaders that we need to engage with to create change related to health and healthcare in our system. And, do you know, I mean, it's a huge undertaking, 180,000 people to have a clinical review by next March, but we're really on the road, and I really believe that we're going to achieve it because we've rethought who the leaders are and who needs to get involved. Last message, number 5. You know, when we think about large-scale change in healthcare, I mean, it's really difficult. It's hugely complex, involves a lot of different people, it's highly political, and the reality is that most large-scale change in healthcare won't work. But the good news is that there are lots of things that we can do as leaders to accelerate this large-scale change to a revolutionary pace. And I think the need for change in healthcare is so urgent that we as leaders, we have to take the challenge. So, you know, what are some of the things that we need to do? First of all, we need to focus on vision and moving people towards that. We have to describe the kind of healthcare system we want in the future and what it will look like and attract people towards it. We need to find ways to frame our call to action, our messages about change in very engaging ways. And because healthcare is so complex, we need to have a lot of different changes at a lot of different levels. We can't just think about having a few leaders at the top of the system who are like big batteries for energy, who make things happen. We've got to create lots of little batteries all across the system with lots and lots of energy for change. We've got to tell a really compelling story to engage people in our change process, and we've got to keep continually refreshing it. We've got to work with emergence, and what I mean by this is that, you know, the changes that we're talking about, they can't just be top-down command and control. They've got to happen at every level of the system, and we can't always control what's happening, and unexpected, unintended things will happen, and as leaders, we've got to learn to work with that. And we've also got to work on lots of different levels with lots and lots of different changes all at the same time. We can't just focus on a few small projects. So I'd say, certainly from my NHS experience, big changes, big challenges, but the potential for publicly funded healthcare, I think, is excellent. And as leaders, we need to step up to the challenge. Thank you.